Okay, thank you. So welcome to TGCT in the youngest patients. During this webinar, all participants will have their mics and video muted. There will be a question and answer session at the end of the expert's presentation using questions submitted through the chat feature. The chat feature will immediately send any questions directly to the hosts. We will allow participants to come off mute and ask their questions live as well. My name is Sydney Stern, and I am the Director of TGCT Programs at TGCT Support, and I will be your moderator for today. I would like to sincerely thank Dr. Scharschmidt and Dr. Gupta for spending their evening here. And we appreciate the interest in this conversation and the discussion around pediatrics in this disease. And thank you all for coming and attending. Now I would like to introduce our speakers. First, we have Dr. Scharschmidt, who is the Director of Pediatric Orthopedic Oncology. Oh, I have slides for this. I definitely have. Okay. Sorry about that. They're very pretty faces here. So we have Dr. Scharschmidt, who is the Director of Pediatric Orthopedic Oncology Program at Nationwide Children's Hospital and a professor in orthopedics at the Ohio State University Medical Center and the James Cancer Center. His interests include bone and soft tissue sarcoma in adults and pediatrics, both benign and malignant tumors, complex limb reconstruction, advanced reconstruction options in growing children, and care options in oncologic amputee patients and spine tumors. Say that really fast. Dr. Gupta as well. He's a pediatric oncologist with Roswell Park in sarcoma in children, adolescents, and young adults. He focuses on Ewing sarcoma, osteosarcoma, and soft tissue sarcoma, treating both pediatrics and adult patients, including patients with TGCT. Dr. Gupta manages the sarcoma clinical trial portfolio at Roswell Park and has opened national trials for GIST, UPS, liposarcoma, and many other in that area. So I will turn it over. I will stop sharing my screen, and I will turn it over to Dr. Scharschmidt.
Awesome. Thanks, Sydney, for the introduction. Let me start sharing my slides here. And I apologize in advance. I have some teenagers that are sort of rolling in after school here, so you'll probably hear my annoying dogs barking at some point during the talk here. So I apologize in advance. So there you go, like on cue. But really excited to give this webinar tonight with Dr. Gupta. TGCT, or as you'll hear me probably slip up several times of still calling this PVNS, has been a long-term interest of mine, both in the adult population, but we're obviously starting to see it more and more, I feel, in the younger population. So, we started asking the question of why, and more importantly, what are our treatment options, or how does that differ from the adult world? So what I hope to capture, I think, is probably the easy portion of this talk, which is talking about the surgical considerations, because they don't differ a whole lot from the adult world, although we'll obviously talk about specifically how I feel that this differs in the young patient. And then Dr. Gupta will cover a lot of the systemic and what is really the emerging technology on the systemic side. So he'll cover that part in his talk as well. So just as a real brief introduction for this, and obviously won't spend a lot of time because I think everybody on the call probably is very familiar, and I'm sure Ajay will spend some time in his talk on the pathway. But we know that this is a rare tumor, but if you're affected by it, it can have a great impact on your quality of life. It's been really hammered out really nicely from a scientific standpoint, the CSF1 pathway and its involvement in this both paracrine and autocrine process that really caused this neoplastic clone to arise and this proliferation within the joint that causes all the pain and disability. And the good thing about this pathway is it obviously gives us a targetable area to look at for more systemic or even locally delivered therapeutic options. Two types of this, both clinically and radiographically, we sort of make a distinction, the nodular type and the diffuse type. We obviously won't spend a lot of time talking about the nodular type, although there certainly are challenging cases of that with recurrence and pain and disability. Really, I think where our biggest challenge lies is with the diffuse disease. And this is obviously the more aggressive of the two lesions. It involves a large part of the joint lining typically. And the knee is the most common site, although we see it across really all all large joints. And the challenge with this, and really why I think there's so much interest in this topic and this webinar, is the high rates of recurrence. If this was a disease that we can offer one medication or one surgery and have a curative sort of outcome, I don't think we would all have as much interest in this. But the reality is the recurrence is way too high for, especially in the diffuse population, and we need to find better solutions for that. We also know there's complications with treatment of diffuse TGCT. They either can go multiple surgeries that can lead to the morbidity of the joint, or be involved in multiple therapeutic options. But obviously, the more sort of lines of treatment you have, or the more repeat surgeries you have, can lead to a lot of morbidity for that particular joint and really impact quality of life. So I would say that the gold standard for this disease, whether we're talking about the young patient or the old patient, or I should say skeletally mature or immature patients, is still, I think, surgical resection. Obviously, we're going to talk a lot tonight about emerging therapeutics as well as some traditional therapeutics for this. But at least somewhere in that pathway, surgical resection, I think, is still the standard. Now, in the skeletally immature patient, I think that has really been the gold standard, because we typically haven't had any good systemic options, although there's more and more coming on, as we'll hear tonight. And we try to really avoid radiation. So you may hear that discussed in the adult population sometimes, is that in multiple refractory cases, or in cases where there's not a good surgical options, occasionally radiation could be considered in those patients, but we really try to avoid that in kids, because number one, it can have a big impact on the growth plate, which can shut down that early and have real long-term implications for growth. But more importantly, really any increased dose of radiation has the potential for malignant transformation down the road. So the younger the patient is, the longer that risk could potentially be. So we've really been sort of stuck, if you will, with surgery being our best option in young patients with this disease. The goals of the surgical resection are really the same as in the adult world. We want to reduce the symptoms from this. We want to prevent joint destruction. We want to improve function and quality of life for patients, and hopefully reduce the risk of local recurrence. And we're going to talk more specifically about sort of the options for this in terms of the techniques of synovectomy, but it can really be done either open or arthroscopically. And we'll sort of go over briefly the pros and cons of that. But unfortunately, as I've already mentioned, surgery alone is associated with a high recurrence rate, especially in the diffuse setting, and that can lead to increased morbidity and really impair quality of life. And obviously, we don't want to see this happen to anybody, but when this happens to a 10-year-old or a 12-year-old or a 15-year-old, my biased point of view is those are the years where you want to be sort of the most active and out doing things. So this can really impact mental health and all sorts of other sort of downstream effects the younger the child is. So we know there's high rates of local recurrence with both arthroscopy and open surgery. And luckily for localized disease, whether you choose either of those approaches, the recurrence is typically low, less than 10%. So again, that's not typically the population we're going to be talking about. But open surgery can lead to increased morbidity and with stiffness and pain. And obviously, again, these repetitive surgical interventions can really have a high impact on quality of life. So again, talking through what's best on an individualized patient basis is really important for surgical decision making. This is some data that we recently got from Sydney and her team, and this is unpublished data at this point. But obviously, her registry is very powerful in helping us understand this disease and patients' pathway and epidemiology of this a little bit better. And she was kind enough to share this data, but I was surprised to learn that 127 patients were between the age of 3 and 17. So what we would call that skeletally immature population. So, I think that's a fairly high number out of the 800 or so patients that are involved with the registry. Out of those, probably no surprise, 88% were diffuse disease, 65% were female. So very similar numbers that we see in the adult population. But a lot of these were diagnosed by their pediatricians or their primary care physicians or general orthopedists in the community. So very rarely, again, and this is another challenge that we see even in our adult population, but very rarely are they getting into the orthopedic oncologist or the medical oncologist where we can really have these good multidisciplinary discussions about best sort of treatment pathways. So, we're really just learning more about this population specifically. And I think that's also going to drive us to find better answers as well. And this was a recent paper that was just published from our colleagues at Vanderbilt that I think is the youngest published case report of any of the family of TGCT in the literature. So this was of the tendon sheath, which again is a little bit easier to manage report of this, but this was a patient that was 21 months old. So obviously we can even see this in the very, very young patients. And I'll show you my case of a kid who presented to me when he was 4 years old. So we're seeing this younger and younger as I think we learn more about this disease as well. And probably no surprise to patients on this call and to people participating in this call, but this journey can be a long, hard journey. The recurrence rate really drives a lot of this, but I would say that a lot of patients who have diffuse disease have a similar journey where there's multiple attempts at physical therapy and there's multiple images with MRI scans and different treatment options. Obviously, pexidartinib being the currently only FDA-approved modality for this in the adult world. Multiple attempts at surgery. But I think the take home from this slide is this is a years long journey with multiple interventions along the way for most patients who are involved with diffuse disease. So the spectrum of treatment options is also all across the board for this. More and more we sort of will think about active surveillance for this if patients are having minimal symptoms, and I think that's really important in the younger patient. Is that sometimes we want to wait for them to get a little bit older, or a little bit more skeletally mature before we start to get into more aggressive interventions, particularly on the surgical side. But there's arthroscopy, there's open surgery, there's total joint replacement, and obviously we always talked a little bit about radiation. But there's a whole spectrum of treatment options. So we try to choose, and we'll talk more the rest of this talk here about how do we individualize that decision, or at least what are the different options so that we can have the discussion with the appropriate teams on what may be right for a particular patient. So just show a couple examples of this, and these are typically all my own patients that we've taken care of over the last several years. But this is, an MRI of a 16-year-old patient who presented first to his primary care and then to a sports medicine physician, underwent a couple lines of treatment, eventually got an MRI, and you can see on this sort of sagittal view here, and I don't know if my pointer shows up here or not, but has thickening throughout both the anterior and posterior aspects of the joint that is basically consistent and diagnostic for diffuse TGCT. And this patient was treated with an anterior posterior synovectomy, and currently he's doing really well. But we can see this all over the body, and I think that's one thing that I've seen in my own personal experience with this is especially in the younger population, we see some sort of atypical presentations for this. So this is a 17-year-old female who presented with hip pain, and on her X-ray she had these sort of erosions around her joint, and we ended up getting an MRI scan, and lo and behold, she had diffuse TGCT of her hip joint, and she went on to be treated with a surgical hip dislocation. We did an extensive synovectomy, including curettage and bone grafting of the sort of peri-articular lesions. And again, fingers crossed, she's currently doing well. But the hip can be a very challenging joint with a higher recurrence rate than we even see at the knee, just because of the technical challenges with it. We've seen it in the ankle joint in young patients. So this was a big nodular localized PVNS in the front part of an ankle in a 15-year-old that was missed as a soccer injury for I think about 6 or 8 months before she finally presented for MRI and eventually got the right diagnosis and curative intent treatment. So, I think the point of these slides is that this should be a disease that we think about in the skeletally immature population when we see patients with pain stiff joints. I think it's been missed for a long time and underappreciated for a long time before we're starting to realize that the true incidence is probably much higher than we anticipated. And this is the child that I mentioned earlier on. This was the youngest patient that I've taken care of in my practice. This was a 4-year-old when he was first diagnosed, and he was diagnosed back in 2010. And since his initial diagnosis, you can see he's had a really rocky course. And this included a trial with imatinib that unfortunately did not show any benefit for him. And he's undergone a total of 6 synovectomies, some open, some arthroscopic, but has undergone multiple surgeries for his disease at this point in time. Luckily, despite the challenges along his path, his last surgery was almost 10 years ago now, and he's been disease-free from a TGCT standpoint. But on the flip side of that, this is his most recent X-ray, and this I got just last year in the office. And he's, I think, 16 or 17 now, and he's doing well. He's playing sports, but he still has some chronic pain in his joint. And I don't know if you can appreciate, but the joint surface is very sort of undulating here. And this is essentially a secondary arthritis that he's developed as a result from all the treatments from his TGCT. So although he's doing well now and he's doing the things he wants to do, I'm very worried about the long-term health of his joint, and likely he'll need more surgery and potentially up to a knee replacement, just given what it has taken to clear him of disease. So clearly, even in cases where we quote unquote win the battle against TGCT, there's still better things that we can do for the long-term care for these patients, and hopefully have better solutions to preserve the joints. So to talk about specifically our decision making when we start thinking about surgery, and this is talking about either arthroscopic or open, because I think that's the biggest sort of controversy when we start to consider how we should address these things from a surgical standpoint. And there's essentially two angles on this. There's a sort of sports medicine-y type angle that likes to do arthroscopy for everything, and then there's an oncology angle that we generally tend to favor open procedures. So how can we sort of make the right decision for these individual patients? So this was a young patient. He was a male triathlete. His race times were down, but obviously still very functional. He had intermittent knee pain and swelling and some mechanical symptoms. And he had a previous arthroscopy about 10 years ago for a tumor that was removed. And you can see he has fairly localized disease to the anterior portion of the knee here. So these were arthroscopic pictures from his procedure, and that brown sort of pigment with the sort of flowy tissue is very characteristic for this. But we can see sometimes, even if it looks localized on MRI scan, there can be more of a diffuse picture when we get in there arthroscopically. But if this is confined to the anterior knee joint and it's something that can be removed arthroscopically, I would say that this is still a good option for this type of disease presentation. But admittingly, there's a lot of controversy in the literature for this, as far as, is arthroscopic good or is open good, and which is better, and which leads to a lower recurrence rate. And there's a lot of cloudiness, there's a lot of gray zones, and there's no right answer for this. And I'm a strong proponent that I think a lot of these decisions need to be made on an individualized basis, looking at patient symptoms and duration of symptoms and quality of life and prior interventions. And all those things need to be taken into account because there's no one clear answer in the literature as far as open versus arthroscopic. We know that we have to get all the disease out. That's sort of the key take-home point. So what's the best option is really going to be a very individualized answer for most patients. And here's another patient who had she was a young female. She had chronic pain and swelling. It's limiting her ADLs. Her range of motion is still pretty good, but she can only walk about a block at a time due to the inflammation from her TGCT. And you can see here, it's relatively limited on these MRI scans, again, to the anterior portion of the knee joint. So this is another patient that was debrided arthroscopically, and an arthroscopic synovectomy was performed. And our goal is, again, really to remove all the disease that we see. All that brown pigment is what we try to shave out and remove as part of that arthroscopic procedure. So she had a good arthroscopic synovectomy. And about 10 months later, so close to a year, she returned, and she was starting to have pain and swelling again, continuing to sort of lose some function. But sometimes in these cases, if it's combined to the front part of the knee, we may consider even a second arthroscopy to try to clear a disease. And that can be a very successful approach for these. But I would also offer sometimes there's a role for both. So some patients who have undergone arthroscopic or have an arthroscopic sort of evaluation and it looks more extensive than what was thought from the MRI scan, there may be a combination for both an open and an arthroscopic approach to try to get the best disease outcome from a surgical standpoint. So, obviously I'm from Ohio State in Columbus, Ohio, so I had to sneak a couple of Buckeye slides in here. But, in this, and I'm talking with really the marriage between sports medicine and orthopedic oncology, is that sometimes getting both teams involved is the right answer. And you should ask providers about that. And we as providers should not be have sort of too big of an ego or be afraid to sort of ask our partners who have specialties in different type of surgeries to get the best outcome for patients. So with that being said, from an arthroscopic standpoint, what are the indications for an open synovectomy? So this was a patient who was a 20-year-old female. She had a local recurrence here you see on her MRI scan, just below her patellar tendon. And this is a hard area to get to arthroscopically. So even in a scenario where there's a hard area to get to where you can't complete a complete resection, especially in recurrent disease, I really feel that this is an area where we think about an open surgical procedure as opposed to arthroscopic. Or in this challenging case, and this was a long-standing patient of mine who you can see his pathway a little bit here. He had an arthroscopic synovectomy. He had multiple open synovectomies. He was on pexidartinib as part of the Enliven trial. He actually was part of the Amex injection trial for the CSF1 antibody, but had continued pain and stiffness. And there's no arthroscopic procedure that's going to help when this disease is this extensive and there's this much degenerative change to the underlying joint. And again, we're seeing these really extensive cases in younger and younger patients. And this is, in my mind, really where the challenge lies. And in these patient examples where, this is an 8-year-old female who clearly has disease sort of all throughout her joint. It's extended outside of her joint in the muscle. It's posterior, it's anterior. And I don't care if we do an open or an arthroscopic synovectomy. I think we're never going to remove all the tumor, all the TGCT out of this knee. So these are the cases where we really need more options to really help the outcomes for these patients. And this is what PBS looks like when we resect it from an open synovectomy standpoint. So when we're thinking about this, there's a lot of decisions that need to be made from a surgical standpoint. What's the sequence? Do we do both anterior and posterior? Do we do this as all one case, or we do it in a stage fashion? Do we do it all open, or all arthroscopic, or can it be combined? And again, there's no clear guidance for this, either in the literature or really in individual large centers' expectations or outcomes with this. This was Dr. Masblum's largest study. This was an international study looking at the outcomes of patients. I think it was around 1,600 patients total, but this is specifically the surgical answers. And you can see here that it was all across the board. Most patients with diffuse disease underwent one-stage open synovectomy, but it was all across the board. So it really didn't help us tell who was doing better. So my practice for this in the pediatric population is that if it's a first presentation, even if it's diffuse disease, it's sometimes hard to tell how symptomatic patients will be from that disease. So even in a setting where we're not quite sure, we often consider arthroscopy as our first step, because that's going to be minimal risk of damage to the growth plate, to the periosteum, and hopefully not affect the overall growth and development of the joint. So we'll often consider arthroscopic approach first. If that fails, or if we decide to go to an open procedure, it's typically an anterior, posterior synovectomy, all done under one anesthetic, because again, we want to minimize the anesthetic exposure, especially in the younger patients. After surgery, the postoperative regimen is of crucial importance here. We typically leave a drain so that we don't get a big hemarthrosis or a bunch of blood filling up the joint. And we start aggressive range of motion. We use a lot of regional pain control with blocks and things like that, and start the patient moving really on postoperative day 0, because we know if we can get that joint moving, that's going to hopefully prevent some of the stiffness and some of the morbidity that we get from some of these procedures. But this is the sort of humbling slide, and this is from that same Masblum study, is that, despite looking across all patients here, there's about a 44% recurrence after surgical intervention. And this is likely on the low side. And when this was stratified out, looking at comparing arthroscopic versus open, there was not a significant difference in recurrence. And there was also not a significant difference in morbidity as far as stiffness or pain afterwards. So again, a lot of gray zone as far as what the right surgical decision is going to be for these patients. So in summary of sort of our surgical decision-making process, we think that open synovectomy is indicated for localized and resectable disease, although we'll consider arthroscopic first in the younger patient. Whatever approach we take, we have to be aggressive with trying to get all the disease out. And it's really on us to set expectations that, there's a high recurrence rate despite optimal treatment for these patients. And I wanted to just end my portion of the talk with just a couple of slides here on joint replacement, because it's obviously not something we like to consider in the skeletally immature patient. But as that patient of mine that I showed you, it's the unfortunate end pathway for a lot of patients who experience diffuse TGCT. And although we try to avoid it, if it's a procedure that can restore mobility and decrease pain and increase quality of life, we'll sometimes consider this even in the young patient, although it should be considered as last resort. One of the reasons we consider it a last resort is not only for the age of the patient, but we know the complication rate for these is higher than it is when we do joint replacements in adult populations for arthritis. For our total knee patients, they have a higher rate of stiffness, higher rate of infections, and a higher rate of the components loosening if there can be a recurrence of the TGCT despite doing a joint replacement. And we see the same thing with our total hip patients. So just to show a couple of examples of what this looks like, this was a 47-year-old, so obviously not quite the skeletally mature, but I would say still a young patient when we're considering joint arthroplasty. But she's lived in the TGCT world for a long time. So she had over a 20-plus year of her patient journey with TGCT, 3 synovectomies, and now unfortunately is under chronic pain. And you can see she has essentially bone-on-bone arthritis, including a lot of bone involvement with the TGCT, and her range of motion is terrible. It's -5 to 30 degrees. So in patients like this who have this extensive involvement, and this is her MRI scan sort of showing all of the bone involvement and the extensive changes, really combining your synovectomy with a joint replacement can be a very good option for these select patients. So, she had an anterior synovectomy. Sometimes by doing the total knee replacement as part of this, we can see enough of the posterior aspect of the knee that we don't have to do a separate incision and a posterior synovectomy. But she underwent a total knee arthroplasty for her long process with this disease, and is currently doing very well with this. And then lastly, this is a hip example. This is a 31-year-old patient, obviously, again, very young when we're considering joint replacement, but he had a 5-year history of TGCT in his hip and has really failed all other conservative management. And he's already got end-stage arthritis. So this is the MRI scan showing his extensive PVNS around the hip. And in the hip, even more so than the knee, the best way to get a good surgical debridement is to do a hip replacement, because we remove the ball part of the hip, the femoral head. So it really allows us to see the entirety of the joint and perform a very meaningful synovectomy. So this is the best surgical exposure we can get for a synovectomy in the hip, which we know, again, is our best chance at eradication of the disease. But again, joint replacement in PVNS or TGCT is something that cannot be taken sort of lightly. And I would offer that this should likely be done in specialized center because the complication rate is higher than it is for most patients. And we're doing this in younger patients. So the chance of needing multiple surgeries over the years is very high in this population. So just to summarize again, we have a lot of different treatment options for TGCT, and we still have active surveillance as an option. We've got a lot of options for surgery for attempted eradication, but the reality is we still have a very high recurrence rate. So for all the failures we've had on the surgical side, I'm super excited to hear Dr. Gupta's sort of update for us on the systemic side, because I think all of our goals, and even being a biased surgeon, I think our goal is to try to turn this into a non-surgical disease. That would be the best case scenario for these patients if we can find some way to eradicate disease without the morbidity of surgery. But I thank everybody for listening. I've left my email on here. I'm sure Sydney can connect you with my contact information afterwards as well if we don't get to all the questions. But thanks for hearing me, and I look forward to Ajay's talk.
Thank you so much, Dr. Scharschmidt. Dr. Gupta, if you want to share, please feel free. And then we'll get to a discussion portion. So feel free for anybody to start putting any questions in the chat as well, and we will get to those.
Oops, let me just switch this. Okay, how's that look?
Perfect.
Great, thanks. So Tom, that was really great. I'm really excited and looking forward to the questions and comments. So I know that we want to keep an eye on time. I do have about 30 slides, so I'll try to go through this pretty quickly. And of course, we can go back to anything that needs more detail. So in terms of a lot of the data, Tom did review. But for pediatric tenosynovial giant cell tumor. As we talked about, most of the patients are adults. When we talk about pediatrics, the average age is about 11. On the right, you can see a classic case of swollen joint. And on the bottom here on the right is actually the youngest reported patient, a 21-month-old, who had a TGCT that Tom touched upon. So it's the rarity is such that there's about 64 per 100,000 cases of joint pain in children are diagnosed with TGCT. And the main thing is that the disease isn't that different between children and adults. And ideally should be treated similarly. And ideally, clinical trials should be extended to pediatric patients. The recurrence rates after resection of localized and diffuse disease is very similar between children and adults, and for localized it's about 85%, and for diffuse disease about 53%. The localized type does appear to be more common, though, as we saw in Sydney in the TGCT's registry data, that sometimes it can be biased towards worse disease, right, and more diffuse disease, and those patients might be who are on this webinar tonight, maybe actually looking for more solutions online, and as opposed to those who have a surgery and are kind of followed after that and don't have recurrences. Median duration of symptoms prior to diagnosis in peds is about 1 year. And this is, again, the same registry data that Tom reviewed, which I think is fantastic because I think this is easily the biggest series I've seen and easily publishable. So I hope that the TGCT support puts it out there at some point because it really is super valuable data. Another series just had 17 patients over 16 years, these are individual institutions, and 4 out of 17 had diffuse disease, and 88% of the total population were disease-free on follow-up, with only 1 patient with remnant symptoms. So just a snapshot of what it may look like. This diagram shows that outcomes really are similar between peds and adults. The green and the blue at the top are the localized disease in children and adults, and then the purple and the yellow are the adults and children. And so you see the diffuse disease really lining up pretty well, whether you're a child or an adult. It really is the same disease. So the treatments, what are we trying to do? We're trying to change the disease burden. We're trying to decrease tumor volume, but we're also trying to improve quality of life. We're trying to affect pain. We're trying to decrease stiffness. We're trying to improve functioning. And here's the time cover for when imatinib was first discovered right around the turn of the century. So treatment can be used most often in unresectable and limiting disease. And imatinib, as we know, has the longest track record of use and is a drug that's been along for the longest that targets that CSF1 pathway that Tom was talking about. And then, as we know, pexidartinib is the only FDA-approved agent, but only for 18 years and older. And now there's some thought about whether or not we can use some of these agents before surgery or to get to surgery somehow in those patients that are previously thought to be unresectable. And so that's something that's evolving. It's still a battle with insurance companies in some cases. In terms of whether or not to consider treatment, there are many considerations, and every patient is very different. You have to think about the degree of symptoms and the impact of quality of life, whether there's radiographic progression, whether there's a potential for long-term joint complications or other complications, whether there's tolerance for treatment and monitoring, for the side effects, fertility interests, ability to follow up, and whether or not there's an interest in clinical trials. So as we discussed a little bit, the CSF1 and the CSF1 receptor pathways are what are thought to be key to this disease. And we have many different drugs targeting the pathway in different ways, whether it's imatinib, and nilotinib, pexidartinib, and vilsetinib, and then pimicotinib, and then now there are many monoclonal antibodies being developed against CSF receptor 1. CSF1 normally helps to control monocyte to macrophage differentiation, survival, proliferation, and renewal of these cells. So these macrophages are important in our surveillance system, but also in our healing. And the other name for CSF1 is macrophage colony stimulating factor. So it makes sense that it plays such a big role in these blood cells. In addition, it helps with tissue damage repair, growth of liver and spleen, and also clearance of damaged cells and repair. Helps with bone and bone marrow effects in bone marrow stromal cells and osteoblasts, and may be involved in the development of placenta. So there can be some concerns when you block CSF1 and the CSF1 receptor connection. Here's a table of all the comparative data up to 2022 in TGCT of the different drugs that have been used widely in adults. Unfortunately, this is where all the data really is for TGCT, whether it's imatinib, nilotinib, emactuzumab, cabiralizumab, pexidartinib, and vilsetinib. And you can see that most of these drugs do have a good disease control rate with excellent median progression-free survival and excellent duration of responses. But really the goal is, can we get it to kids and is it safe? So imatinib, as we all know, targets multiple tyrosine kinases, including CSF1R, so that kind of I guess we were a bit lucky that it included CSF1R in all the kinases that it affected. The side effects include edema, rash, fatigue, GI toxicities. There's very rare liver inflammation, and there can be blood count issues. So the pros of imatinib that it's a well understood side effect profile, that there's minimal monitoring required, CBCs from time to time, and up to 70% of patients can have improvement in symptoms, but unfortunately, tumor in most cases does not shrink. Typically, the patients have to be on therapy for a long period of time. And it's generic now, so it may be expensive, although there are things like the cost plus pharmacy and other avenues through which imatinib can be affordable. Here are the outcomes with imatinib in one series of 62 patients in Europe, and there was a 29% response rate, with a majority of patients discontinuing after a median of 7 months, likely due to toxicity or patient choice. In terms of long-term toxicities with imatinib, they are very rare. It is really a well-tolerated drug, but you should note that in this less than 1% column for long-term toxicities, you can have cardiac toxicity, secondary malignancy, myositis, multiple sclerosis, renal failure, dermatitis, pancreatitis, hypophosphatemia, gynecomastia, low globulin immunoglobulins, opportunistic infections, hepatotoxicities, pulmonary toxicities, skin effects, and cerebral edema. So not insignificant by any means, but overall decently tolerated. In terms of TKIs and imatinib and growth inhibition, it's a very real concern, and it has been well documented as imatinib has been used widely to treat young patients with CML. So we have a lot of data on what imatinib can do in children. And so the hypothesis as to why TKIs cause patients to be shorter while they're on treatment is a disruption of the growth hormone or IGF-1 axis, potentially alteration of bone metabolism, impacting bone remodeling. And I've seen multiple indications that it may disturb processes within the growth plate itself. They had 94 patients in this study with CML who were treated for at least a year. And from 1 year to 1.5 years on imatinib, only about 20% of patients achieved what would be considered normal or average growth. And another study reflected just that. 73% of patients had a decrease in height, but once they reached puberty, those growth velocities came back to normal, and I saw that no patients were stunted. Another very interesting topic is imatinib or TKIs and fertility. and it's well known that imatinib adversely affects oocyte and sperm maturation, gonadal function, and overall fertility potential, but it is self-limited in that when you stop the drug, you can regain a lot of these functions. As has been reported, imatinib does cross the blood-testis barrier, and so this can reduce sperm count, sperm density, sperm survival, and overall activity. But imatinib has no effect on sex hormones or on the actual reproductive organs themselves. Imatinib is pregnancy category D, so it's been shown to have risk to a fetus, but may still be used in pregnancy if the benefits outweigh the risk. So there was a study, a very large study of adults of risk, at age of potential fertility on first or second generation TKI, who were on these TKIs at time of conception. And so you notice that in women who had outcomes detailed, only 50% had a term birth of a normal infant, 4% had a pregnancy complication, 5% had a congenital anomaly, although that may be in line with normal population. 22% of pregnant women went for termination of pregnancy, and 16% of pregnancies ended in spontaneous abortion. By contrast, in the men, 87% conceived pregnancies with term deliveries and normal infants, with complication rates much less than those seen in females in the single digits. So we'll move to pexidartinib. This is a direct CSF 1R inhibitor. They are oral pills, and the most common side effects include hair color changes, fatigue, itching, nausea, and diarrhea. The pros to this are that it is more effective than imatinib in that you can see tumor progression, and you can also see improvement in symptoms. You can induce long-term remissions, allowing patients to come off therapy, and there is a patient assistance program, although for adults. The cons are the significant liver toxicity risk that requires a REMS program of very close monitoring, very invasive weekly lab monitoring for the first 2 months, and that it has very specific needs in how it has to be given, and has to be 2 pills twice a day. So it's has benefits, but also has big risks and is not yet available in pediatrics. The Enliven trial showed some very impressive response in both tumor regression, but also in quality of life, with long responses as well. And then again, the REMS toxicity is really serious. And I've seen some patients with very prolonged cholestasis and prolonged liver enzymes. Of note and of interest to this group, per the label, pexidartinib may cause harm to pregnant women and may impair both male and female fertility. But of course, we don't have long-term data as this is a new drug. There is at least one study I found of pexidartinib use in pediatrics, and this was the study of pexidartinib in refractory leukemias and solid tumors, including NF1-related neurofibromas. And they did develop a milligram per meter squared dose for the pediatric patients, so it is going to be a body surface area dose, and they found that it was really well tolerated. So the third dose level was the recommended phase 2 dose of 800 milligrams per meter squared. So they didn't have any TGCT patients, unfortunately, but they did have patients with CNS tumors, sarcomas, mesothelioma, leukemia, and NF1. And what were the toxicities of fatigue, decrease in the white count, increase in creatine kinase, serum amylase, headache, anorexia, vomiting, diarrhea, and hypopigmentation. So all seems very tolerable. I didn't see any note on if they looked into growth velocities or anything like that. And they didn't report anything on fertility or anything like that. So of interest, it's always interesting when you do these trials, the pediatric dose is actually higher than the adult dose. And so we'll see it often, as you see, children are able to tolerate more drug than adults do. And so long-term data on how this goes will be really of interest. So vimseltinib is an oral CSF1R inhibitor. This was studied in the MOTION trial. Again, this was for adults, twice weekly for patients without surgical options and symptomatic disease, and it was given for 24 weeks with a 40% overall response rate. The adverse events were increase in creatine kinase, headache, edema, nausea, fatigue, myalgia, arthralgias, and rash. And it sounds like edema was much more of an issue with vimseltinib than pexidartinib. Of note, the EMA is going to discuss uncertainties regarding the impact of this drug on bone toxicity and reproductive toxicity, and that discussion will have very important implications for pediatrics. I think more is still pending on that. This is just a review of the MOTION trial. I think we've kind of reviewed that data and how it was successful. Then pimicotinib is another oral CSF1R inhibitor with minimal inhibition of c-KIT or PDGFR. And this was a BISCO study in phase 1 and then a maneuver study in phase 3, which is placebo-controlled and close to accrual. Again, this was in 18 and older and was treated also for 24 weeks and then open label. There is hepatic toxicity here. They do see that the Kupffer cells in the liver are targeted, but no serious liver injury seen in patients so far, which is great. And 68% of patients had shrinkage of tumor and 90% remained on treatment, indicating some good tolerability. Most common adverse events were laboratory changes, rash, itching, and face edema. And there was interest, they tried 2 different doses and they saw much more adverse events in 50 milligrams, much less in 25 milligrams, and still had pretty decent effect with the 25 milligram dose, as you see here, with 2 complete responses and 6 partial responses, with 8 out of 12 having an overall response, which is great, and everyone really having some decrease. Next, we have our monoclonal antibodies. So this is interesting. This emactuzumab is interesting because it is open to 12 and older. And in at least the European document I saw, the adolescents are not randomized to placebo, the 12 to 17. So that's wonderful and I think important. This is an IV infusion every 2 weeks for 5 treatments and then 3 months of observation. So it's a shorter duration of treatment, which is nice. In this trial, they were doing it for patients without surgical options or high risk, and any prior treatments were allowed. So there have been very impressive responses by imaging and by especially by PET scan. Seems like PET scan may be more sensitive for response than the MRI. And 71% had a complete or partial response, which is quite impressive, with 98% disease control rate. Side effects are, we kind of reviewed, but there definitely is quite a bit of swelling, and that swelling can be facial, extremity, or around the eyes. Then most recently, there is an intra-articular injection. So all these drugs have these systemic toxicities, but if you put it directly into the joint, maybe you'll limit the amount of toxicities to the whole body and really concentrate the drug where it needs to go. So this AMB05X has completed their phase 2 trial where they gave an injection every 4 weeks for 6 injections. In the earlier trials, they showed improvement in 8 out of 11 patients. And so looking forward to seeing that data as well. Now, this is a nice table that compares the toxicities that have been known so far for all of the agents that we're prone to use. I think the ones that we're most interested in are, of course, the emactuzumab, because that's open to 12 and up in clinical trial, the imatinib and pexidartinib and bosutinib. I would say the AMB05X is a little too early to evaluate, but pexidartinib has the most hair color changes. Nausea and vomiting you really see more often with an imatinib. a lot of fatigue with all of them, really, but especially pronounced in imatinib and pexidartinib. The liver is the biggest worry with the pexidartinib, but a little bit in vimseltinib. Taste changes with pexi, headaches in imatinib, pexi, and vilsatinib. Swelling is particularly an issue with the intra-articular injection as well as imatinib, although we do see it with emactizumab as well and the others. Lab changes can be seen, rashes, and then muscle and joint aches. There is another IV antibody that's being developed, but currently we are unsure of the status. It's called cabiralizumab, and their side effects are creatine kinase elevation, edema, and hypertension. So I think we'll stop there. That's my email address, and we'll have, I'm sure Sydney will pass out our info.
Unmute myself. Thank you guys so much for your wonderful talks. And Dr. Gupta, I love the table at the end. So as people start asking questions, many people also submitted questions prior because they can't wait for the recording. And so I wanted to ask you both. So imatinib maybe being the one with the most amount of information, but do they generally have an impact on fertility long-term, both in males or females?
Yeah, so it's hard to say, we definitely recommend that you stop imatinib if you are pregnant or trying to get pregnant. So that is, a recommendation that I think is on the label. And then it sounds like if you stop imatinib prior to getting pregnant or in that situation, it sounds like your ability to conceive is not affected. So that's what I've seen so far.
That's helpful. Yeah, that's always some patients. And I remember when I was diagnosed at 17, they brought that up before I went on imatinib. So another question very similar are there uncertainties or long-term side effects with these drugs that we don't know about after their trials? And I think this is probably a general question regardless of pediatrics or not. Dr. Gupta?
Yeah, like that, I tried to highlight some of those long-term toxicities in imatinib that are really rare, less than 1%, but when you're treating 100 people, that's going to be at least one person that has it. So always a concern, and really only going to come out once you've been studying these drugs for 10, 15 years. And so like that table showed, we really only know for imatinib so far.
Thank you. Give some surgeon love also to Dr. Scharschmidt and ask, what is the youngest patient you've given a replacement to, and is there such thing as too young?
Yeah, for TGCT, I think the youngest patient is probably around 17 or 18, but we've done other joint replacement in kids as young as 11 and 12 for different problems. So, there's not really too young of an age for that. The challenge is, especially if the skeleton's still growing, the risk of loosening of the components can still be higher, and the risk of just wearing out the joint over time. So I wouldn't say there's a young age cutoff, but in general, the older the patient, the better.
Well, that's good to know then. I remember always that they always consult. We hear it all the time that you're too young for a replacement. So it's like nice to know the consideration is more about where the joint and the bone is, but also with long-term revisions in mind. So, Dr. Gupta, you mentioned that imactuzumab enrolls 12 and over. Why is that one different than some of the other ones? And just for some reference for people in the room and maybe you as well, if you enroll anyone under the age of 18, they have to have prospect of direct benefit. So they're automatically given the drug. They can't be randomized to placebo. So that gives, I guess, an opportunity for them to always get the drug.
Yeah, I thought that was a really great aspect of that clinical trial design. So I don't know. I think it might be advocates like yourselves and the group, the TGCT Support. I must imagine that someone must have been an advocate for pediatrics in the room when the trial was being developed that said, hey, we really should include those that are younger because, hey, the disease really isn't different between adults and pediatrics, so why not? So thanks to those advocates.
That's helpful. And hopefully, let me spotlight to make sure that everything gets captured the right way for the recording. I'm not sure if Spotlight does anything different than pinning, but now we'll find out. Thank you guys. Um, so Dr. Scharschmidt, does scar tissue development after repeat surgeries impact growth, or are there considerations related to that?
Yeah, for the most part, scar tissue isn't going to impact growth, but it does cause pain and stiffness in the joint that can obviously have some long-term implications. So, as long as the synovectomies are done carefully and the periosteum, the covering over the bone, is preserved, most of the time the growth itself won't be affected by this. So, that's, I think, one of the challenges with these systemic treatments, and I know Dr. Gupta hit on them a lot, but the effect on bone development, I think, can't be sort of understated, because it's really, despite all these clinical trials, it's really an unknown sort of outcome right now. And I know the data on imatinib would suggest that there can be a stunting of a growth and it recovers. But for some of these more targeted agents, we simply don't know the answer to that. So I think it's really a void, and really one of the things that's holding up the extension of these trials into the skeletally mature population.
So when you say skeletally immature, what age range, what cutoffs are those?
Yeah, so typically, I mean, there's no hard cutoff for that, but typically we use around 16 or 17 for girls and 17 or 18 for boys, as when they sort of start to hit skeletal maturity.
That's good to know. This is kind of a question for everybody, whoever's requesting the MRI, but is there a specific concern within these pediatrics or young adults even for contrast use and repeat scans that are done probably for a significant portion of someone's life at this age?
Yeah, so obviously MRI is going to be better than CT scans, just for the no radiation dose. And that's an interesting question about the contrast. But as long as the kidneys and things are healthy, then contrast is typically well tolerated. But I will say, in a lot of patients, if we are sort of undertaking an active surveillance pathway for diffuse disease, we don't always need the contrast with that scan. If we're just looking for change in either resist or tumor volume score or overall growth, then sometimes we won't get contrast every time. We'll try to space that out to minimize that, although it should be fairly safe. I don't if Dr. Gupta has different feelings on that.
No, I agree completely. I think, I was actually curious about that myself, and I was looking into seeing if repeat or long-term exposure to gadolinium could cause adverse effects, and it's not really clear. It's not well studied how much gadolinium and how much frequency of exposure to it would cause adverse effects. So I agree with Tom. If you can, the first few imaging are going to be with gadolinium, and then after that, if you have stability or you're able to, see the disease without need of contrast, that's optimal.
So I guess similarly, and this is probably my question, so you may be able to tell, but given with the contrast, is that ever used for your assessment of drug efficacy based off of whether the tumor is taking up more contrast versus not? Is that a potential marker for whether the drug is working, at least in drugs that don't show like advanced shrinkage?
So yeah, I think Tom can definitely answer that. But in my experience, radiologists do look at certain contrasted features as forms of disease response. But when you're looking at stability, or a patient is doing well and not having new symptoms, maybe contrast can be avoided.
Yeah, I agree. I mean, we have some pretty good data in the sarcoma world that the different contrast patterns and different imaging sequences maybe can predict response. I think we don't have enough information yet in TGCT of what that necessarily means as far as contrast enhancement. I was intrigued by the PET data that Ajay showed a little bit of, and we've gotten sometimes inadvertently PET scans on patients with TGCT, and they are very metabolically active, and you do see a decrease when they respond to some of these targeted agents. So, cost and insurance is always a battle with PET scans, especially for a quote unquote benign disease. But I really feel that may give us a better idea of response than MRI can even.
So for those that are unsure of all these words we're throwing out, MRI uses a magnet to determine your features, we'll say, and how the electrons move based off the magnet or protons, and a PET scan is based off of a radio labeled tag of glucose that you consume, or usually through IV, and that goes around your body and you can see how it moves. So a tumor may take up more of that label, so you can tell. For those who are like, wow, these are a lot of acronyms. So someone actually just did ask about a PET scan. And so as providers, do you prefer a PET scan in this disease? Is there a use for PET scan regularly, giving the radiation dose, et cetera?
So that's experimental, I would say. I mean, like Tom noted, we really don't use a lot of PET scan, and so that data was quite interesting to see that they included it in the study. And on top of that, PET does have a significant radiation dose. So, MRI does avoid some radiation dose, but then has more contrast. So yeah.
Another question we were asked is, how do you walk a patient or their family, in this case, through the discussion of whether to wait and see or active surveillance versus picking a treatment? And maybe Dr. Scharschmidt first, since maybe you first.
Yeah. So there's a lot that goes into that decision, obviously. And these, when we see a new diffuse TGCT patient in the office, especially in the pediatric world, I mean, this shouldn't be booked as a sort of 15-minute follow-up appointment, right? Because these are typically fairly long and can be involved discussions, because, we take a lot of factors into account. Patient age, obviously, being one of them. If we can avoid surgery in a 4 or 5-year-old, or try to push that down the road, even by a couple years, that may be safer. We use function is probably the biggest number one, function and pain. If you have a child who's, has some intermittent swelling, but is still playing soccer and able to do that at the level they want to, and maintain that level, then maybe active surveillance is the right answer. Obviously, with this disease, sometimes we get lucky and people can fall into that bucket. But more so than not, it really becomes a question of, what surgery should be considered. And as we talked about during the presentation, that can go in a variety of pathways. Or, if the patient's a little bit older, 12 and older, obviously, but as some of these ages become more accepted in the adolescent age range, I think it's going to be an even more involved discussion. And not to get too much in the weeds with that answer, but I think the neoadjuvant approach is also something that we're very interested in. Is there an agent that can decrease the morbidity of surgery, or make the surgery easier with a lower recurrence rate by using it first and then doing a surgery after a certain period of time? So, I think I didn't answer your question at all, Sydney, but it's a very long, complicated discussion, I think, is the take home point.
I think I got the gist of that one, at least from that. Dr. Gupta as well.
Yeah, I agree. I mean, typically when the patients are coming my way, the surgeon has felt like either they want to start something neoadjuvantly, before surgery, or because surgery is out of the question. So at that point, the patients are pretty symptomatic, and we are starting something like imatinib. Some of them will see me, they'll talk about the side effects, and they'll be like, oh, my quality of life is pretty decent. Maybe I'll hold off on that until things get a little worse. So like Tom said, it is an involved discussion with the family.
So in the spirit of involved discussions, including sports medicine doctors and having that multidisciplinary care, would you say, Dr. Scharschmidt, is it better to have a large surgery where there is a potential of removing all disease, or conservative surgery, which would potentially leave some behind, but give opportunity for recovery or whatever reason based off of skeletal maturity?
Yeah. Again, very individualized discussion for that, because the goal of an open front back synovectomy is obviously eradication of all disease if possible. And there are certainly cases that even when you look at it, you're not going to be able to remove every sort of nook and cranny of disease. So in those cases, especially depending on the patient's symptoms, it may not be wrong to, especially in the young patient, to say, let's give this a try of arthroscopic synovectomy. And some skilled arthroscopists can even get posteriorly in the knee and perform a synovectomy back there. So, starting with minimum, knowing you may leave some disease behind, but if you get lucky and you can have a 2 or 3 or 4 year disease-free interval until it starts to get symptomatic again, the child's going to be larger, their skeleton's going to be a little bit more mature, and maybe you have more options. So I would say, especially in the younger patients, we try to probably more than in the adult world, we take that approach of conservative operations as the first step, and then sort of accelerating as need be.
Thank you. I thought this question was really interesting because that's not something I had ever thought of. So someone had asked, is contraception required when peds are put on, or pediatric patients' children are put on some of these medications? And how that dynamic works, obviously at 12, 14, 16, it's all going to be a different conversation. But do you have considerations there?
Yeah, so you can have an honest discussion with them, and if they're sexually active, then yes, you would advise that. And if not, then some places will just check a urine for pregnancy regularly, and that's just part of protocol.
Okay, so there's at least a range of options. I thought of that question, and I could only imagine having that conversation with a parent in the room, and it would have been very awkward.
Yeah.
And then lastly, as well, to thank you guys for your time. So I don't want to take too much. So we have two other questions. One being, do you have any pain recommendation or pain control management recommendations for young kids and athletic or active adults that maybe can't be on narcotics, chronically?
Mm-hmm. Yeah, I mean, and we wouldn't want to or recommend sort of an opioid sort of answer, obviously. So we never go to the narcotic route unless it's acutely in the postoperative stage for a little while, but try to wean off as soon as possible. So, this is an inflammatory process, and we know very few cells in the big sort of tumor mass of TGCT are actually neoplastic cells. It's a lot of just inflammatory cells, right? So, things like getting on a good anti-inflammatory or prescription level anti-inflammatory. Occasionally, we consider things like cortisone injections. Again, none of these are going to be curative for the TGCT, but they may help from a symptomatic standpoint. So that's sort of our standard from a pain management standpoint.
That's helpful. Thank you. I think we get asked about that quite a bit. And then lastly, this is probably for Dr. Scharschmidt, is do you typically do surgeries in young, we'll just say adolescents, as one stage or two stage surgeries?
So I'm assuming that is if you require a front back, if
Yeah, for
the
the
decision's
knee.
been made to do a front back synovectomy. So there's different schools of thought on that, but my practice and what I've been happy with is doing it all in one single stage. I think there's a couple considerations of why, and one is to minimize anesthetic exposure, especially in the younger patient. Although it's relatively safe, if it can be done under one anesthetic, the better. And I think the recovery, it's going to be a little bit of a tough recovery either way. So if we can do all that in one staged operation, I've always been a proponent of that as opposed to doing the anterior synovectomy, and then usually people will recover for about 6 to 8 weeks and then come back and do the posterior recovery. So now, you're talking about several months of recovery as opposed to trying to do it just in that first 6 to 8 weeks. So, albeit I won't say controversial, but there's different schools of thought on that. But that's my personal opinion on that.
I think you're ahead of your time because Dr. Randall actually just recently published a paper with 191 patients that showed the same recovery and same outcomes related to one stage versus two. So I think you're way ahead of everybody else in that regard.
I'll tell Laura that next time I see him. So
thank you both very much for your time, particularly on this very important subgroup that doesn't get as much attention. And so I really appreciate it. And I will send you any additional thoughts that patients may have from this webinar as well. So I want to thank everybody for their time and all of the audience as well.
Thanks, everyone.
Yeah, thank you. It was great.
Thank you.
Sydney, thanks for organizing as always.
Thank you very much.